Hi, I'm Ralph Preston, and every Tuesday we have these Stroke Buddies Recovery and Science Zoom meetings. And today we're really honored to have Dr. Paul Winston with us. Dr. Winston's a leading Canadian physiatrist and clinical associate professor at the University of British Columbia, and he's renowned for his pioneering work in neurorehabilitation and spasticity management. He serves as the medical director of rehabilitation and transitions for Island Health and leads the rehabilitation medicine team at Victoria General Hospital. Dr. Winston's career is distinguished by his innovative approach to patient care, including the development and global dissemination of ultrasound-guided diagnostic nerve blocks and cryo-neurolysis for spasticity, a groundbreaking non-surgical treatment now being adopted internationally, and probably the reason a lot of you are here today. So let's welcome Dr. Winston. We really appreciate your time, taking time away from your busy schedule.
Thank you so much. I'm just going to see if I can get the slideshow to launch and let me know if you can see all of my slides.
We're good.
Perfect. Okay. Well, thanks for everyone for joining in. I like doing these talks because I've tried to shorten it enough so there's lots of time to ask for questions. If you have a burning question during the talk, I'm absolutely fine with you asking the question or just making note to yourself. So we're going to talk about a new treatment for spasticity. And I guess if this is a stroke group, most of you have a pretty good idea what spasticity is. You either live with it or you have a family member. And we're going to talk about why we had to come up with a new treatment. And the simple reason is that people were not getting well enough. One of my biggest mentors is Dr. Lisa Boivin, who is a bioethicist at the University of Toronto, but she's also from the Dene Nation in the far north. And in her work with Indigenous consent and artwork, she really describes that when we engage a patient into the medical field, we actually have to see who the patient is. We have to explain what the patient has and do our best to inform the patient about what's going to happen to them. And let's face it, in medicine, we're really bad at that. We rush, we tell people to do things, we don't truly tell them what's going on. And often a lot in other fields, we don't actually know what the patient does day to day. So we don't take into account what happens when we're not in the room for 10, 15 minutes, what their needs. So I'm going to show you a lot of patients, and they've given me their consent to share their story, but these are unique people that gave us their trust. So I'd like you to think about and thanking them for being part of this. Um, when we give a talk, we're meant to give disclosures. So I have received funding, education from multiple companies that make botulinum toxin and cryoneurolysis. And this is my colleague, Dr. Daniel Vincent, an anesthesiologist who had the eureka moment to decide to do cryo for us back in 2017-18. The purpose of the talk today is we're just going to review what spasticity is, why we really needed treatments, and to see how cryo-neurolysis fits in that window of ever expanding treatments. The problem with spasticity is nobody understands it, and we're still debating internationally what to call it. So I like the term my colleague Thierry Deltome says it's spastic muscle overactivity because it's muscle overactivity to understand all the different types. So if you do not live with spasticity, the simplest thing that I'm going to just ask you to do is just create a tight fist with an arm that moves and pull it towards your face as hard as you can. And I almost want it to hurt so that your fingernails are digging in, and I want to keep it there. And over the next minute while I'm talking, try to extend your arm and open something up, but take a minute, resist every moment. And that's the fight in your body. So when we go to open and close our arm, our muscles know to relax and stretch as needed. We don't think about it. But in the spasticity, when the brain is injured or the spinal cord, the muscles can't relax. So all the muscles contract at the same time. So you can't just open and close your hand at will. You're trying to open your hand, but the closing muscles are working and vice versa. But when you wake up in the morning, the hand might be wide awake. When you look around, your hand might open without your control. So it's a lesion in the control of relaxation and movement. And that's what makes spasticity so hard to treat. Now, what's really shocking is that half of patients who have a stroke, because we're focusing on stroke today, will develop a contracture within 6 months. And a contracture just means is that no matter what we do, the limb can't move past its endpoints. Your arm can't go up, it can't straighten and open, you can't get your heel on the ground. And we don't treat it very well. And we talk about spasticity, but not the actual contracture, the unbreakable limitation in movement. Another group from Australia said no matter how much physical therapy you get, you can't stop a contracture, you can't improve it by stretching. You can maintain it, but all that stretching on its own will not work. Now, when work started looking at how we could change it using medicine, there was a lot of work started looking at a drug called phenol, which is still used. So used a lot more in America than other countries because botulinum toxins are outlandishly expensive in America. But phenol, you can't use it in Germany today because it was a favorite way of the Nazis to kill people. So you would inject their heart and they would have an excruciating, instant, painful death. Well, not instant, enough to cause pain. So it's banned because of its abilities and it causes damage to structures. It's used many places. It's used on kids because you can't give them enough toxin, but it is a corrosive, deadly uh, drug. The same thing with botulinum toxins. They were developed by the military in the United States and around the world as a bioweapon. It is a at high doses, it could kill a country. It's used very safely. I use lots of toxin. You're not at risk using it, but it is developed from a strain that is biomedical warfare. So you have two structures that were used traditionally as deadly in a safe dose, but this is the potential. So neither of them, phenol is not FDA approved in America. And in the United States, toxins have very limited indications, and you can't treat it in a lot of body parts, and you can't treat it everywhere, and you have a maximum dose. So it's just not possible to treat a whole body with botulinum toxin. And evidence, particularly in kids, has not shown that it would increase function. So we decided that we needed more ways. Now, Paul, you mentioned Dr. Peter Ree. If you don't like blood, close your eyes. But this is some of the surgeries from Dr. Mark Mahan, who's a wonderful pediatric surgeon in Salt Lake City. Surgery works, but there's a limited number of targets you can have surgery. And if it reinnervates and grows back, what do you do? How many scars you can have? And there are very, very few surgeons in America that can do this. They're phenomenal. And it's really good when it's combined with other surgeries. Like Dr. Ree is a master of what he can do, but it's a limited approach. So not that many people can access it. So we've created the Cryoneurolysis. We did our first case in 2018. And Ralph, you mentioned, so we do training. I like it when a whole group comes together to teach. So this was the group up from Harvard, and we've had 5 of their doctors training. They get a Canadian license to treat patients. So it's really exciting when they come. And this is our global outreach. So we have patients in the white who travel very far distances to get treatment. We have doctors in green that travel from all over the world, and purple are the centers now offering this treatment. Pink of where I've gone to train. So it's really expanding around the world very quickly. And just to give you an idea, these are some of the names of people I've trained, and they might be near you. And these are a lot of the top American spasticity experts that have come for training, and really wonderful people. If you want your local center to learn a little bit about it, we published this book in 2023 and just really updated it for this purpose in 2025. 31 authors, many Americans, everything to do with nerves for spasticity. So not just cryo, phenol, toxin, a way for people to really understand how to do it better. We get very little money for each copy, so we sell it to teach, and there's about 65 videos in the book that you can share and learn from. So the important thing that I need to tell you is what I learned from my journeys in Europe is there's something called a reducible deformity. And a reducible deformity is when I ask a patient with spasticity, is your hand always in a fist? And they'll say, no, when I wake up in the morning, my partner can open my hand. Or sometimes when I'm not looking, my hand opens. But as soon as I go to move it, it clenches it. Other people, yeah, I've never lifted my shoulder up here. It's impossible. I get skin breakdown. So what we normally did when we saw a patient for botulinum toxin is we'd kind of reef on their arm, see if it would move or stretch, inject, and then hope for the best. and we didn't show that the range of motion could get better. In France, they really figured out that if you did something called a nerve block, if you put anesthetic, lidocaine, dental freezing around the nerve, you could paralyze the nerve and see how far it could stretch. So in that case, you could do a surgical procedure on the nerve or a botulinum toxin or an alcohol like phenol and get a better result. But if it didn't move, you would need another type of procedure. And no one really taught me that here in North America. So this is what a reducible spasticity is. This is from our documentary. This is the worst case scenario. And we show worst case scenarios every single day. This woman has severe pain. Her pain is her limiting factor. She doesn't have function in that arm. So she understands after our nerve blocks that we did that her arm will move better, but she won't be able to do it on her own, but her pain would go away. Because what cryo does is it treats the pain nerves and the muscle nerves. So you can see her 2 months after the procedure. I was able to predict her outcome before we treated her because it relaxed with lidocaine. So look at the range of motion change. It's quite dramatic. She doesn't have the motor power to move on her own. So when patients come to see us, we are very clear, you have paralysis under there. You won't be able to move your arm a lot more yourself or a little, but she is moving it better. But the stroke took away her power to move. But the pain is gone and the relaxation. And now the thing about cryo, people say, well, how long does it last? This is 1 year later. It has lasted very well. She's maintained almost all of her gains, but she wants more. And as we keep training patients and treating them, we add more and more muscle groups. So we added a new group of muscles under here, and her arm really relaxed. There is no way she could have done a Superman before the procedure. She just couldn't even get the arm up. So instead of being in pain when I'm moving her after the second procedure, she's laughing, right? So this is her immediate recovery. You couldn't do that after surgery. You'd have scars, you'd have total anesthetic, you'd have to heal. We treated so much on her the first time. We exhausted our like 2 hours and she was done. So we just treated her foot the first time. But at a year, her leg was stiff. So we treated a thigh muscle and look how high she can lift her leg and march. So what we've done over the years is we add more and more muscle groups. So that's what a reducible deformity is, one that responds to a nerve block. So the reason why we have hundreds of videos that we share, and people still say, do you do best case scenario? We don't have bad outcomes to share on videos because we always block them first. So we know what the patient's going to look like. So we can say, we have a pretty good idea this is what you're going to look like. If we can't change it, we don't do the procedure. We don't just ram you full of drugs and hope for the best. So this is Cynthia, and if you've seen our movie, Cynthia is one of our hero patients, one of our first study. She came up from Fort Worth for treatment, and she is a never stop, Energizer bunny who had a traumatic brain injury. She has a baclofen pump in her back. She had surgical lengthening in Texas. Wonderful care, but she wants more. And one of the things with her spasticity is she said if she closed her eyes, she could do a punch. And she actually punched me. And I was like, whoa, okay. But then she can't do it again. Her arm is stuck. And her
For
hand
me, I think
works. So she didn't want me to treat her hand, but her thumb gets stuck. So when her thumb gets stuck, she can't use her hand. But she was afraid to lose hand function. So we put her in our first study because that's how we treated patients. But you can see how her thumb goes over. So we decided to treat the shoulders and the elbow for her first. So if we look at her after her treatment, about a few months, she's getting much better range of motion. But it's still, there's paralysis, right? And stiffness. So even though Dr. Boissonneau can get her overhead, she hasn't unlocked that power. But this is way better. She can get it open, external. She said, I can do so many more tasks. I don't need to go overhead, but the stiffness, it's getting so much better. So all of these movements are better. And she still has a little bit of tightness in her elbow, so that's a not reducible, and some tightness in her shoulder. But she said it was life-changing for her. We also did one of her leg muscles as well. And she said she wished she had not had surgery on the leg because we would have treated that. So you can still see there's a little bit of tightness in that arm. So, she goes off and what she can do. So she went from one punch to really punching from the power she can generate. she came back after a year. Our study was complete, and I said, we have new things to treat under the armpit.
Okay, excuse the crazy hair,
With that.
but I want y'all to see something that I haven't been able to do for 12 years.
So I want you to see the power that she can generate with her punching now. But the fact that she can reach her head is completely different. But she's still in this position. So even though she can do her head and she really likes it, I wish I had that much hair so I could do my own. But she can't do this. So this is the non-reducible part. She still has some stiffness that a nerve procedure will not do. But she's thrilled. She can do all these new things.
Ta-da!
And now I don't have to do it and get yelled at because I did
So I
terrible.
said to her 9 months later, I'm trying some new things, come back for treatment and we'll do something. And this is a technique I also learned in French called le scrunch scrunch. And scrunch is the sound of scrunching tendon. So you hear. So this is described in the book Madame Bovary in the 1800s. You take a needle and you scrape away a tendon. So it's actually less painful than cryo because you just numb the tendon.
Overhead, it'll be sore.
Oh my God. Okay. Okay, seriously. Did you see that?
Do it again.
Shh. Am I the only one who's amazed here?
So, no, I'm happy.
Can you believe that, Jeff? Look at that. Look, Jeff, look at this. This is my hand touching my right ear.
So for her, it was that tendon residual that we had to treat to do a tenotomy. And this is right after the procedure.
I feel the reach. You did it yourself.
By myself.
Okay, do it again. Do it again.
I mean, is no one else amazed by that? I haven't done this for 12 years by myself.
And now she has to go home and do aggressive physical therapy to regain movement and power in her new range of motion. And, she went right to the gym from clinic. So, this is the recovery for her. Other people are very exhausted from the procedure and might need a couple days rest. So we created this whole procedure, and every patient that comes to us, everybody wants to be like Cynthia or other patients. And we say, well, no, your stroke left you with this capacity for movement. We expect that. So every patient that I treat, whether it's toxin or cryo or other, I like to do blocks first and say, look, this is where we're going to get you. Is that okay? Do you want to go under a treatment? Do I have your consent to proceed, even if it means you can't walk again, you can't lift your arm overhead, but things are better, but just not perfect. We can't undo the stroke or the multiple sclerosis. So here's another case. A young woman, she had a stroke at 18 and high functioning, regained her life, works. She just hides that arm, doesn't let anyone see her arm, which has no tasks. She's now left-handed. And just look at her face when I try to move her. So shoulders quite good, but elbow, wrist, and fingers really fight her with activity. She can run, but she has clonus. And for those that you don't know, clonus is that shaking that you get with spasticity, which gets in the way. So when she tries to run, she limps, it's stiff, and her whole leg feels tight and resisting. So she doesn't like it. So she's just accepted that she doesn't use her right arm for function. So we did nerve blocks and immediately everything relaxed. I actually put little splints on her fingers just because she doesn't have power to say, look, you can get the power back. You just have to learn. And I'm just going to stretch your fingers. And she loved this. And the clonus immediately got better. So we planned for cryo about a month later for her really to, understand what this meant. And she came back. And she documented her changes with me on videos and with texts. So this is the day of the procedure, learning to use her hand again. This is the day after. No, okay, this is an amazing outcome, but I bet a lot of you can't throw a tennis ball as good as her. And she hasn't done it in 19 years. One of the things that people tell me all the time, and therapists get worried, patients get worried, doctors get worried, you're going to paralyze my patient and make them weak. And many have said when they had toxin before, they had weakness. Well, we are so selective in choosing muscles that we leave some of the finger flexors and do others. So we take out the ones that are spastic most, and leave the others for power. So she's relearning how to work immediately. And, every day she's sending me a video of a new activity. This is one of my favorite shots because she did the video herself of, getting that wrist all the way back. And she's retraining her brain right now. This is brain training. Now, can you tell which is the spastic hand anymore? They both look the same.
Right one.
Trying to play tennis again. Each activity running much faster, looser. And she said, I don't fight my therapy anymore. So the interesting thing was at 10 months, she called and said, I feel like it's wearing off. I'm getting stiff. So she came in at a year and it was wearing off. It was still really good. And we retreated her and she sent me a video that night, like everything's back. So if we need to retreat at a year, big deal. Like it's great. And hopefully if we treat her once a year, maybe for 3 years, we won't have to treat her again. So what is cryo? Cryo is putting a needle in the body on a targeted nerve, causing immediate destruction and breakdown of the nerve, so complete that the muscle relaxes. We have learned through our research and our publications and our hours and hours of studying where each nerve to each muscle exists. We can do an individual muscle or an entire large nerve like the median nerve or your funny bone nerve, the ulnar nerve. And we learned how to do it. So this is a man who just had a stroke a few weeks before. And in Canada, botulinum toxin is free in hospitals and free for people mostly. So we can do it all the time. And we treat our patients early. But he had a stiffness, a resistance to movement. And we do the cryo and the muscle relaxes and completely gone. This is another patient that we treated who was 2 years post-stroke, had had a lot of toxin injections, a non-functioning hand. But when we did the nerve blocks, I said, you know what? I think your hand's gonna open. And we treated her, so she is learning how to use her arm. And the change in flexibility and mobility was great. She's one of these really I call bulldozer patients. You're not going to get in her way of her therapy. And she's really worked hard to stretch. Not everybody can. A lot of people have fatigue, tightness, other illnesses, and that's okay. Just getting you in a good position is okay if that's what you want. So Dr. Hashemi is showing how tight the hand was before, and now she can pick up things and feed herself. Any movement? A lot of the patients need tenotomy, and we're just going to publish a paper on 15 patients like this, where this is a published case report as well, where she was so tight after 10 years of botulinum toxin, we did cryo, we could see the tendon popping up, we cut it, and the range of motion is much better. So we do the cryo for the spasticity, then we can see the tendon, and then we cut the tendon. So how is it working? I've been talking a lot about cryo, but what exactly happens? So what we do is we freeze nerves. So we put a needle, and there's different manufacturers. We put a needle in a body. We put gas, in this case, laughing gas, through the needle. It passes through an aperture, causing the needle to freeze very cold, minus 88 for nitrous oxide, and that makes the water around it freeze. So just to understand, with cryo, we don't put anything in your body. There are no drugs. It is a probe that gets cold, like licking a pole in the winter. You can't move your tongue. It gets stuck. Your water creates ice. So that's the catheter that we put in. We just put gas through it. As the gas goes through, it goes through the aperture, and then the probe gets really cold, and it's really fast. What we know at the temperatures that we use up to minus 100, we put our ice probe on the neuron, and the neuron breaks down and it has to degenerate. kind of like getting sciatica, a nerve damage in your back, and you get foot drop, you can't move it. So that nerve breaks down, but after it breaks down, it starts to regenerate. So at these temperatures, it's very safe. The nerve will lose its motor or sensory phenomenon, but it will grow back. If we do really cold temperatures of minus 100, which is a special equipment with argon gas, that will kill the nerve. And that's only used when you have a tumor that you want to kill the tumor and all the blood supply. We do not damage tissue. It is like freezing a chicken breast. You can put it in the freezer, take it out, and eat it. There is no damage to anything else. It just damages the nerve, no other structures or blood vessels. As we've gone along, patients became very greedy, very selfish, and wanted to be better. How damn them. And they started seeing, but I want more, I want more. But as we could move them more and more, we suddenly had access to muscles that we could never treat before. So we started adding more muscles and publishing these approaches. So we have lots and lots of case reports and publications in our book to teach them. This was a woman that we treated in Copenhagen who, the neurologist didn't even want her to come see us because they said there's nothing you could do. You broke your shoulder won't move because you fractured it. But I'm like, I don't think so. So we did her muscle, and you can see, again, it's not perfect after the procedure. It's still quite tight, but it's much, much better. And now she can get access to cleaning her armpit, getting dressed, many things. But that tone in the shoulder was so bad, and it was not all due to the fracture. And the reason why I know this is after we muscles, that's what I found in her armpit. This broken down skin, all cut, pain and discomfort that she did not know existed. She was horrified to see this picture of her armpit. We cleaned her up, we did the extra muscles, and she was so much better. So the neurologists were wrong. The great thing about cryo, when people say, is it new or experimental? No, it has been used since the 1960s and 70s. We have been freezing nerves for even longer. It has been used to get rid of pain for many, many decades. So when we do cryo, if you have pain in an area, we can also treat the sensory nerves to get rid of pain. So people are always worried about numbness. Yes, we do have some patients that will get unwanted numbness, but I can tell them I'm super, super sorry, but it will come back. We know it will regenerate. So even if you're numb in your knee or your hand for a few months unexpectedly, it will return to normal. Yeah, the other thing is people are worried about weakening and muscles shrinking. So this is a boy with cerebral palsy. His elbow can't go straight because his bone was formed in that shortened position. It will not, you can't reset the bone. But rather than shrinking and atrophying, which we know when we do botulinum toxin, the muscle can get atrophied. We see that on imaging. We lengthen it, we open the muscle. So on the left is 2 months after, on the right is before. You can see how much bigger the muscle is because you stop the contraction and the muscle gets bigger. And that's why the patients are stronger. We are generating bigger movements, bigger muscles that can generate more power, not taking them away. And this is Dr. Boissonneau showing the muscle stimulating. We are just getting the muscle we want in this case and freezing it. Turn your hand over. So when you come see me, you get a nerve block, or my colleagues. We do a nerve block for people who have active movement, and we say, do you like this? And then we do the cryo after, because we want to make sure the patient isn't too weak or numb from the procedure. So this woman travels from Vancouver, so we would do the block in the morning and the cryo in the afternoon, so she can really decide if she wants it. We have a lot of patients like this. 9% of people who live in care homes in America have fisted claw hands. It is very painful. It is not neglect. It is not the nurse's fault. It's not the family's fault. It's not the patient. It is severe spasticity with contracture. Typically, patients have dementia, so if you try to move them, they scream. So it's nobody's fault. But we know that toxins might open it a little bit, but it's contracture. It is pain. So we treat the motor nerve and the sensory nerve in these cases. So we numb them and relax them. So it's a double whammy. You basically make the hand have no feeling so they don't feel pain. This was a man, again, that we treated in Denmark who, he had advanced dementia. So it was very uncomfortable for him. His family was very distressed, and he had contracture of the hand. On the left, you can see the tendons popping up. So that's what they would call contracture. But I knew it was reducible deformity and I could fix it. And then when we did the hand, I actually just forced the fingers open because they were now numb, and you actually breaking scar tissue. So we were able to relax everything.
So sorry, bear with me. I'm just gonna try to open this as much as we can. Start with that one there. I'm gonna try to open this one. Alright, that's about as far as we can get there.
Open and close your hand now. Open and close. And if I do this.
Oh.
Okay, painful. Sorry. We won't do it again.
So my colleague, Dr. Muse, there's 5 of us in the clinic that do the procedure. This was her patient, but entered our study, and I just filmed for her. And she's selectively just doing the 2 fingers that were a problem. She doesn't have to do anything else. And in this case, we felt it was all stiffness, not really sensory pain, because the other fingers were okay. So she can selectively go after just the flexor digitorum superficialis, or FDS muscle, which is right here. And then we just break the tissue in the joint that's stuck. And relax and stretch her, and she'll be better. This is a young stroke patient from the States that came up for treatment. She had a stroke as a very, very young child. So she's developed with what's called spastic dystonia. And spastic dystonia is this. When she tries to use her arm, the hand just contracts. So it will relax if she's not doing anything. And we know that toxin does not work here. Surgery is very complicated. You don't want to cut the tendons because they actually relax. But she has a completely non-functional hand.
It's much looser and much easier.
And bend your elbow and straighten it so that you put pressure in. Good. And come back. Good. Now pull your hand away from the wall.
Wow.
And now turn it over to face the sky.
Wow.
And now you can just try the different things it can do.
And just her arm is very relaxed now.
Back. Good. Good. Relax the arm. Straighten the elbow out. That's good.
Look at your foot.
It's
That's
crazy.
what Simon says. Simon says touch your nose. Simon says put your arm down. Simon says can you reach all the way up to your head? Good. And can you like play with your hair? Good. And then open your hand. Good. And then touch your nose. And then
So when I followed up with her, she had just started college, and I said, what are the things, I said, you're going to have a hard time using that arm because you haven't. She said, well, one of the best things is I live in an old dorm, so there's doors everywhere. So I can now open doors with that hand. So I can carry things in my other arm. I can do all my things, and now I can use that hand as a helper. I can open doors. I can, lift things, which is life-changing for her.
Heels are on the ground.
So feet are really difficult and complicated. And, in America, some of the botulinum toxins don't even have indication in the leg. We just got one in Canada from Zeoman because the evidence is very low and it's below the knee only, the treatment. You can't treat above the knee for some of the toxins because they haven't been shown to be effective enough. So this is an example of a multiple sclerosis patient who was walking on her toes. But we do a nerve block and discover that we can actually relax the foot. So it is possible for her to get a heel down.
and now do that on that side.
Oh, look at that.
What's different?
That moves.
What normally happens?
It doesn't.
So by relaxing muscles that put down, you can suddenly regain the power that you don't have. So this woman said to me after she has cerebral palsy, she said, do you think I could jog? And I'm like, I don't see why not. And she came back the next week jogging. Yeah, a lot of toe curling.
What's different?
Wow, this is incredible.
Keep going the other way. Look how fast. Don't worry about holding it. You were walking so fast.
Wow. I haven't walked this fast in years.
I haven't walked this fast. So claw every time she took a step, and she couldn't advance her foot. We're getting more and more selective, and really, I'm getting quite bossy with myself when a patient says it's not right. We keep trying to see if we can get more. Some of our patients, though, I say, look, you actually need surgery. Your calf muscles are too short, and they will decide if eventually. Sometimes I can more easily convince them to get surgery, but she had a very nice outcome. This guy had a lovely outcome. And, 2 years ago, I would have said you needed surgery, but we've been able to add more and more muscles. So we do a block, get up and walk, block, get up and walk, block, get up and walk. And after we did all those blocks, we brought him in for this cryo, and immediately he is better. So he's quite happy. He just kept swearing because that's one of the few words that he has. So we affectionately call him the OF guy because he loves that because he was so excited walking away. Interestingly, one of the comments families tell us all the time for patients that have speech disorders and aphasia, they are more understandable after. They start moving their body more and seem to have more motor connections. So incidentally, many parents and family members have said, they talk more easily now. We can do any muscle group we want now, which is really exciting to meet the goals of the patient.
You're one of a kind that you only find once in a lifetime, made to fit like a...
And as we say every patient, we're not looking for perfection. We're not asking for, quote, normal. We're asking for improvements that meet your goal. This was a young man we treated in Switzerland in February with cerebral palsy, and it was so hard for him to sit in his chair. His legs were cramped. When he'd go to transfer, his dad, who's getting older, has to lift him because the legs were just stuck together and flexed. And he just sitting in the chair after, he just scooched over, really simple. Legs are relaxed. He can do it on his own, very happy. We're not going to make him walk. We're not going to be able to give him big movements, but look how relaxed he is after. So for him, that's a huge improvement. People tell me every day, your patient should be getting weaker. This is a soldier. He has multiple sclerosis. His legs are stuck, and we treat the muscles, and now he can march. And when he came back a month later, he was that much better. We've been adding a lot of hamstrings. We've been adding more and more muscles, and it's quite crazy to see how much more length you can do. But what does that mean functionally?
Up to your waist.
Lift.
Yeah, bend it.
So after the procedure, she just kicked her foot right up to her head, grabbed her foot, and said, wow, I am way looser.
Good.
She went back to yoga the next day. So just to wrap up, because we're talking about stroke, there are a lot of children that have strokes either at birth or shortly after, or kids or teens. We see them in our clinics because we are the referral center. And Children's Healthcare Atlanta has done over 60 patients. They'll probably easily hit over 100 this year. And we have trained Shriners. We've trained Yale. We've trained Stanford. I've got a pediatric hospital coming from San Diego. The team in Lexington, Kentucky is ready. We are going to be treating a lot of children soon.
I close my eyes and I can see a world that's waiting up for me, that I call my own. Through the dark, through the door, through where no one's been before, but it feels like home. They can say it all sounds crazy. They can say I've lost my mind. I don't care, so call me crazy. We can live in a world that we design. 'Cause every night I lie in bed, the brightest colors fill my head. A million dreams
have a anesthesia project, and I've really convinced my colleagues, so I'll be able to do up to 6 children a month, which is absolutely incredible. We have a lot of studies. They are mostly listed on clinicaltrials.gov in America. And I get asked all the time where I can get treatment. So before I go there, I'm just going to mention safety. So safety has been my number one concern. I've had, if I got criticism or even dismissal, people were worried about pain or side effects. And I kindly point out that this is a treatment for pain. The machines are called pain ease, pain. It is a pain treatment. It was designed to treat pain. So when we looked at our first 113 patients, 277 nerves, 96.75% reported no side effects after. The procedure itself can be quite painful, but after they did not. And the patients that had pain after, there were 9 of them out of 113, we discovered that you have pain if you don't do enough cycles of freezing. So if you leave the nerve partially intact, they will get some burning and twitching. So you just treat them again. So if they, at the end of the procedure, they're saying my foot's starting to burn or my arm is cramping, we do one more treatment, meaning there's a few nerve fibers left we didn't do. Of the 9 patients, 5 of them needed a treatment, and they all resolved. Of course, every side effect is horror to me. I will wake up, I will feel terrible. But the other thing is, we've discovered that most of the time when people call back with pain, it's not always the treatment, it's the change in the muscle, it's the stretching, and the fact that they moved it. You are in such a different way, you're walking on new muscles. So we have to treat those. Those are side effects from the change in function and movement. So I'm happy to say, when we have a side effect, I die a little bit inside when someone's in pain, but our patients are really good about it. They come. Many have said, "Oh, I was in agony for 2 weeks after, but I didn't bother calling you because I expected it." Like it just. But if I compare it to a surgical recovery, it's very fast. So changing all the structures, tendons in your body, has problems. I do want to share with you, I was given permission. This is a current study. If you want to take a screenshot, this is a study going on in the USA right now. It is a multi-center study treating the muscles of the shoulder and the elbow. All across America, they are recruiting patients. And what you need to know when you get a study, though, it is what's called a sham control. So 2/3 of the patients will get cryo treatment. 1/3 will get a machine that doesn't actually produce the lesion. And this is how, for the FDA, when you treat pain in the knee, you have to give 1/3 of the patients a sham. The good thing, though, is if you go to a center and you get a sham, the study is only 4 months long. You will go back and you can have the treatment. So you will be part of that clinic. So, I'm hoping that all patients who are getting connected to these treatments can then get treatment outside of the treatment area, but you'd be really helping America to get approval. And if you, I hope you can see the QR code. Can you see the QR code on your screen?
Yes.
Okay, because if you can't photograph it, yeah.
Also, Dr. Winston, if you have a link to your survey, I can put it in the description underneath the video so people
Okay, I will just send you the slides after and you can put it in.
Anything that you want, contact information, surveys, anything you want, send to me and I'll make sure to include it.
So you can share this with your group. We do a lot of everything we have done has been grassroots, so social media and training. All the manufacturers of cryo are small companies. They don't have billions of dollars to spend on RX&D, education, promotion. So we are doing a lot of it ourselves. We have an international society, and my website, Academy of Rehabilitation Cryo. I'm very excited. We've just created a huge number of educational videos, and I'm literally fundraising from the manufacturers right now. If you follow me, I'm about free. I don't like people with disabilities don't have money. So we try to do all education for free around the world. But my students have just created this new website. You can go to this website. And if you actually want to be on the website and do a personal story video about what it is to live with spasticity, you could contribute. And we are putting in education about spasticity every day. This is self-funded by my students.
Cool.
And finally, like I said, Ralph, you mentioned at the beginning that you spoke to my nurse. So just about my entire team, except for my research lead, are funded by research grants. Our positions are not unionized. They don't have research positions and assistants in our union. So we have to fundraise for them and through grants and monies. So even when American patients come up, I do all treatments pro bono. I don't make any money. I give up my time for free, and I ask Americans to pay my foundation. So by paying my foundation, I can continue to train and hire my team because the treatments are long. We're taking a lot of data. So every American that's come to me has been pro bono to me, but they pay for the fee that they're meant to pay to the foundation so that I can keep training and doing research. And patients donate because they know that it means other people can get care as well. So I'm going to stop sharing here and open it up for questions.
Wow. If you send me the links to those to the patient website and other things, I'll make sure they're also
Sure.
in the description.
Dr. Winston, my name is Mindy, and I want to thank you for coming on here and Ralph for having him. I'm Winnipeg, and I was just wondering, who do I go to in Winnipeg? I know this was kind of asked, but I was just going online going, oh, where do I go? Where do I go? I couldn't find it. I couldn't find, there's different ones that come up. And my family physician said it's not available. I never heard of it. So I need help to where to go and to talk to her about that.
By the way,
So Mindy, go ahead.
She's in Saskatchewan in Canada and
No, Manitoba,
No,
Ralph.
Manitoba. Sorry, I didn't know if you said.
So
Anyway,
I will tell you this. One of my someone who follows me on social media actually bought the equipment for Winnipeg Health Sciences. So it's at the University of Manitoba for Dr. Karen Ethans. So she has the equipment. The patient actually bought the equipment and donated it so he could get the treatment. We did it as a workshop there. So Dr. Ethans has the capacity. Limited because the hospital is not being very easy about opening it up to patients. However, I've trained more patients from Saskatchewan than anywhere else than Harvard. So Saskatoon and Regina have some wonderful doctors who would do. And then I treat here as well. So you're covered by Manitoba Health is free here, but for out of province patients, you do have to buy the probe from the company, and that costs in Canada $700. In the US, I think it's about, if you do it in the US, they have different ways. So we treat you for free in Victoria. You can even get Hope Air to fly you out if you don't have the funding. So it's free from me because I get paid by the government to treat you. But Dr. Ethans would be someone that you could talk to. She could also do an assessment for you. She's an amazing doctor. And we would like to have more people in Manitoba.
How do you spell her last name?
When Ethans.
ETH.
ANS. Ethans.
Thank you. Yeah, okay. Thank you.
And like I said, I've had patients fly across the country on Hope Air that pays for all your costs. Yeah.
Thank you. That's hopeful.
Surely there
Are there
are
other
questions.
Yeah, I've got a question. Who at Yale have you trained?
So her name is Dr. Jennifer Hankinson, and she's amazing. Really, really hungry doctor. She came up and actually asked to have a longer training session. I also trained her colleagues, so there's two of them. And they've been underway and treating. They really want to start doing kids. They just have to get approval. But Dr. Hankinson now has a long waiting list because she needs more time. But she's treated. She literally went home and just started treating like the next week.
And down in
Burke in White Plains? Is there someone? White Plains
Yes.
in
Actually, you're in the best place possible. So, Dr. Jasmir, sorry, what's Guman, Ghuman. I've trained two doctors at Burke and also at Burke in the Bronx, Brian Lee. So Jazz Guman, she's amazing, Ghuman, and there's a couple doctors from her center that I've trained. They're great. So you're in the perfect place to get treatment.
Beautiful. That's very close for me too.
That's
Okay.
Yeah.
Mount Sinai. There's Mount Sinai. You can get Dr. Escalon's group, who trained Dr. Guman. So two in Burke there. Philadelphia, a wonderful team at UPenn. I just trained another doctor in Philadelphia, so we have a lot of people in that area now.
What's the name of the doctor at Mount Sinai?
Escalon, Escalon.
Hello, this is Valeria Holland, and I'm in Dallas, Texas. What about doctors in this area?
I sure do. So Houston was our first American center, and one of their fellows is now in Dallas area. Yes, and we're training a bunch of people there. Let me just I'll just get her name there. Her name is, let me just get it spelled correct. It's Tulsi, Tulsi Pandat, Pandat. I think in Dallas, I get a little bit confused because they're all UT hospitals. So there's a bunch of UT hospitals between San Antonio, Dallas, Houston, but it's Pandat, Pandat. You can ask for her.
Pandt?
DAT.
Okay. And that's in the Dallas-Fort Worth area.
I think I have to check.
Hello, Dr. Wonder. I have had cryo-neurolysis. I had it in early January of this year by Dr. Wonder in Regina, Saskatchewan.
Yes.
And for me, from what I understand, it should last about 6 months. For me, it seemed to only last about a week. And I'm planning to get it again here in Saskatoon by Dr. Jeremy Hood.
Okay.
And I'm wondering if there's something I should be doing to make sure it lasts longer this time.
Yeah, so the question is, the first time he did it, what the muscles were, if there was the underlying dystonia, which is the movement disorder, or not enough muscle. So it depends on what condition you have. Some people, we have to treat a lot more muscles. And when we first start, we're a bit nervous to treat a lot. And so the feedback we got from patients was treat more rather than less.
Okay.
But I'm glad you're trying it again to figure it out. Yeah.
Is there something that would make someone ineligible? I mean, I've been getting Botox for like every 3 months with very minimal benefit. I happen to have central pain syndrome. I have it very severe, head to toe on my right side, my dominant side. And so I have intractable pain. And so something like this would address that pain?
So unfortunately, central pain comes from the brain. So most people with spasticity have pain around their joints because of stiffness and tightness, which cryo helps very well. It will not address central pain because central pain is irrespective of the nerves. It might make movements easier, but we have not been able to address central pain. It would make the muscles move more relaxed. It would help with the spasticity and like movement of a joint. But in my experience, people have central pain. It's just everywhere. It doesn't matter what the movement is.
Yeah, I have both spasticity and I have the severe pins and needles and body spasms. So would it address one of those?
It would address the spasticity for sure. Well, I would hope you would know with nerve blocks. The central pain is, we all hate it as physicians because we hate it for our patients. Yeah.
Yeah. I've been
Brain
told,
stimulation is probably the best thing.
well, but that's invasive, correct?
Yes. And no guarantee as well.
Correct.
Dr.
There's a
Winston,
couple of questions in the box. Okay, go ahead.
I just wanted to say I have been diagnosed with thalamic pain syndrome, central post-stroke pain.
That's what I have.
And I have been using transcutaneous spinal cord stimulation in physical therapy. And that is non-invasive. And it's a form of electrical stimulation. And I just had it this morning and I came back and the pain and spasticity is gone from my leg.
Right.
So now it's temporary. I'm getting about 48 hours from 40 minutes of active overground gait training using the transcutaneous spinal cord stimulation. But I have a personal unit on the way so that I can use it at home. So if I'm getting 2 days of pain relief from 40 minutes of electrical stimulation, that's pretty good.
That's what
That's
I
great.
have,
And
Polly. I have, when I had the stroke, it grazed the thalamic, so they say I have thalamic pain, and that's why I have sent CPS.
But
and some people are getting implantable now. Like I know some doctors are doing implantable nerve stimulators. There's one other question in here that phenol can damage surrounding environment of the nerve, which is not preferable. So what we know about cryo is phenol, as I mentioned to you, it's a toxic corrosive substance, so it will destroy whatever it touches, and we see that in the form of fibrosis in the tissues. You know, they will say reassuringly that should get better over time. Cryo does not damage the surrounding structures. We ultrasound the patients before and after, and at the temperatures we're doing, it does not damage the structures. If you want to do an ablation for a tumor, it's very good at that, but it's at a much colder temperature. So that's why we feel that it's very safe. And when they've done cell studies on rats, when you take a transection, the tissues are clean and they grow back well. So that's my colleagues in the States that do a lot of phenol have all said they've enjoyed that aspect, that there's no maximum dose and they're not worried about damaging other structures. Very good question.
I'm in New Brunswick, Canada. Is there any in the Maritimes?
Not yet. My colleague in Montreal, Dr. Bursick, would be the closest. Bursuc.
I don't mind traveling.
Okay.
What are the wait times usually?
You know, I think for this, because we're all really promoting it, it's not long at all. People wanting to do it quickly. Quebec's a little bit funny though in Canada. It has its own healthcare system.
Quebec's funny, period.
So they're the only province that aren't covered on reciprocal agreement. So like it's free for you to come here, but there you may have to pay and get reimbursed. Sorry, this is Canada, folks. We don't charge for things like this. But yes, that would be the closest to you.
Okay.
Well, I have some good news for the people in the US. When I went in March, I had to pay in advance because it was not covered by insurance. I submitted a claim and they covered the nerve blocks and they covered the ultrasound guidance so that my claim could go to Medicare, which does cover cryo. And I'm going back in 2 weeks, and it was actually approved by my primary insurance. So I'm getting insurance coverage for cryo. So that's a big, huge step also to making sure it becomes more available in the US.
And it is covered by Medicare. So a lot of my patients are, yeah.
You just talk. How do you get the? Hold on. Am I okay? So can I ask a question? But how do you
Yes.
get? Oh, can you hear me?
Yes.
I've never done this, so let me think. Sorry, I went blank. So I'm a bit worried. I'm traveling by myself, and I affected left side, and and I broke my hip about a year ago. The stroke is about almost 3 years, and so the leg, I don't understand the leg really, because I try to mow with the the mower outside. I'm trying to, but I've been so tired lately. Like the leg, when I wake up, it's a little bit like this, and then I step on it to kind of make it, more even. And I can't even tell if I'm progressing or not anymore sometimes. Like I can walk around my house without the cane a little bit. But sorry, I hate talking in public, like, on the thing. So anyway, so I do have a little bit of the supination, especially when I get the supination a little bit. When I get tired, I even get the pronation. And then the knee, I'm very disappointed because I ordered a stair stepper. I have a treadmill, but I have to hang on. And the stair stepper, before the Amazon guy left, I said, please, can I get on it with you here? And it was such a nightmare. I thought it was more progressed along. I tried to get the other leg, the left one, on the other side, and I had to have him taken back because it was too weak. So, and I'm a fighter. I want my damn leg back. And so would this work? Like, would you be able to, for the knee to bend more? And what was the other thing? And I guess, is that my ankle? But anyway, would the cryo weaken that? Like, would that help at all? Having
No.
for the knee. Oh, and hyperextension a teeny bit. Could it
Yeah, so
help
these
for
are all
that?
great questions. We don't know until we see someone in person and try blocks. And that's why we do the blocks first to see if it helps. One of the things to explain to people with stroke as well, like for you that have central pain, is the brain often doesn't know where
Oh,
the
I have no
body is.
pain.
Okay, but
I
just for
actually
some of
have
the
no
other people,
pain.
Carol, for some of the
Okay.
other people, there are body perception problems. So some people experience pain, some people have no feedback. So not always your body knows where you are in space when you're walking, which contributes to the problem. So that's why we always do blocks first and see how the body responds. But we don't know until we assess someone in person, and we can't legally give advice out of state or province. So we have to see people in person to see. Yeah.
Well, she has an appointment to see you later this month, I believe.
Yeah.
So actually, I had to reschedule. My puppy went in heat, and I couldn't take her to the boarding place. So it's not till September. And I have been
Yeah.
kind of scared, like traveling, because going to Walmart is like a big deal, but yeah. So, but I'm scheduled in September.
Oh, September.
So, yeah, I'm working on yeah.
So if I could just ask as a follow-up, so just so I'm clear, with regard to the intractable pain that I have, the chronic pain syndrome, it would not address the severe pins and needles, but it would address the spasms. Is that correct, as I understand it?
Yes. Yes.
Okay.
Because the pain from central pain is actually not in the nerve or the muscle; it's coming from the brain perception. So
Okay.
it's already up there. Like by blocking it lower down, that's not where the problem is. The problem is actually in the brain.
Is that true with numbness also?
No. So the thing is, cryo addresses numbness. So we are able to knock out the sensory nerves for many people because they actually don't feel. So I always say, if you're already numb, we can't give you back sensation. But amazingly, a lot of people, when we treat their spasticity, they say, I feel more. And the reason why they feel more is they're getting more foot contact, more grip, their brain is perceiving more stimuli. So it's not that they're unnumb, it's just that they have more points of contact. Their brain is feeling the movement in space better. But patients that are actually completely numb are great candidates because they don't have any pain with the procedure. And if we take away large nerves that have sensation, they don't notice at all. So in fact, when a patient says we're numb, we're like, yes, because there's way less chance of, it allows us to do a lot more if you're completely numb.
What type of doctor does that scraping for that crunching? I've developed that crunching in my knee.
Traditionally, it is surgeons, so orthopedic surgeons or plastic surgeons would do them. We're just starting to do it here in North America, but it's routine for because pediatric orthopedic surgeons have been doing
It's
it for children
gross.
forever. Yeah, so yeah, it is.
It's really
We put
loud.
on music. We put
Yeah.
it on music.
My father said the other day, "Is that your leg making that noise when I was going up the stairs?"
Yeah, but that might be the joint as well, which is a different issue. But if it's the tendon, yeah. All right, I have to get to clinic, everyone. So thank you so much. Ralph, I'll send you those extra slides.
Thank you, thank you, thank you.
Thank you very much.
Yes, thank you very much.
Thank you.
All right.
Thank you.
Thank you.
All the best. Okay.